Bismillah wa salatu salam ala Rasulullah. Assalamu alaikum. So this is Dr. Talal Tawil, and the next few minutes I'm going to be presenting a short treatment guide for Helicobacter pylori for primary healthcare physicians. So the objectives of the talk will be very simple. So it's when to test for Helicobacter pylori, and what are the modalities available to test for Helicobacter pylori, and finally, just a few brief slides about the treatment options for Helicobacter pylori. So the first question is, when do you actually test for Helicobacter pylori? So these are there's a lot of indications for treatment of Helicobacter pylori, but these are the strongest indications for treatment. So just to clarify, we shouldn't be testing asymptomatic people. At the moment, the guidelines don't recommend that. But the strongest indications in the literature are peptic ulcer disease, whether active or having a past history of it. If the patient has gastric malt lymphoma, which is associated with H. pylori, after endoscopic resection of gastric cancer, having uninvestigated dyspepsia. So when someone presents to you with dyspepsia, that's one of the indications. The first thing is to check for Helicobacter pylori. If the patient is on or plan to start long-term non-steroidal use for example, rheumatological conditions, it's a good idea to check for H. pylori and eradicate it to decrease the risk of peptic ulcer disease. And then the last two, having an unexplained iron or vitamin B12 deficiency. This is really when the patient's been worked up totally for other causes and there's no clear cause found. One of the tests, one of the causes that can be looked for is H. pylori. And the last one is idiopathic thrombocytopenic purpura. And very important as well, whenever we test for H. pylori and we detect it and treat it, always request a follow-up test to confirm eradication. So this is extremely important. Now, the available modalities for H. pylori testing, there are two types. So there's a direct testing, usually with endoscopy, and there's an indirect testing without endoscopy. So they are all accurate. The first three, the endoscopy ones, we'll leave those up to the gastroenterologist. So it's not routinely something that would be accessible to primary healthcare, but something that is accessible to primary healthcare physicians are the indirect tests. So the urea breath test, the stool antigen test, and the serology. And out of these indirect tests, the easiest test that's available in Kuwait is the urea breath test. And now it's actually available directly for primary healthcare physicians. They can request it directly from the nuclear medicine department in the hospital without the need to refer the patient to internal medicine or gastroenterology clinics. The stool test is available in some centers in the Ministry of Health and the private for patients that cannot do the urea breath test, for example, pregnant ladies. The serology is widely available. However, it's not recommended because it does not cannot confirm eradication, tends to stay positive all your life. And it has to be validated locally, and the tests that are available here are not validated. So we don't recommend using serology. So I think the test that I recommend for use for primary healthcare physicians is the urea breath test. Now, we'll talk about treatment next. And just to show you, there's a number of international guidelines that look at the treated Helicobacter pylori. So you've got a couple of North American ones, and then there's a European one. And more recently, there's a local one from Saudi Arabia, also giving a more regional take on the matter. So what I'll do is just quickly go through the summaries of these treatment guidelines, and then we'll come up with something that suits like more of a local recommendation at the end. So start off with the Maastricht 6, which is a European guideline. And if you look, I took the part where we look at the clarithromycin resistance. So that's very important. You need to know your clarithromycin resistance in your area to determine which algorithm you go to. So in Kuwait, we have a high clarithromycin resistance. So we'd go through the algorithm where the clarithromycin resistance in the community is high. And the first option is either the bismuth quadruple therapy or the non-bismuth quadruple concomitant therapy, which is basically the triple therapy. So amoxicillin, clarithromycin, and a PPI plus metronidazole as well. And then you have the second, third, and fourth line there. I won't go through them because I think at primary health physicians, I think if the patient fails first line, I think they should be referred to either internal medicine or gastroenterology clinics. So if we move on to the American College of Gastroenterology guidelines, they divided by penicillin and macrolide exposure, penicillin allergy and macrolide exposure. And if you look here, if anyone has had a macrolide exposure, meaning if they've had macrolide in the past or they come from an area with high clarithromycin resistance, the recommended treatment is also the bismuth quadruple, although you could also use the levofloxacin triple therapy, which is levofloxacin, amoxicillin, and a PPI as well. This is the Canadian guidelines, and what they recommend in areas with high clarithromycin resistance, a bismuth quadruple therapy, which is PPI, bismuth, metronidazole, and tetracycline. And the other option is also the concomitant non-bismuth, which I mentioned earlier as well. And the more recent guidelines from Saudi Arabia, what they also divide them into first line therapy and penicillin allergy. So if you look at first line therapy when there's no penicillin allergy, or if there's a penicillin allergy, the first line is also the bismuth quadruple, as you can see here. Whether if you have the pills separately, so if you have bismuth, metronidazole, tetracycline separately, you can use them in your country, or if you don't, you can use the Pylori, which is the combined tablet, which I'll speak about in the next couple of slides. So if we gather these guidelines together and come up with a local suggestion based on the high clarithromycin resistance rates that we have in Kuwait, my suggestion would be, this is my personal suggestion, is a bismuth quadruple therapy for 10 days is the best option. A concomitant non-bismuth quadruple therapy is also another option, but has to be taken for 14 days. If the patient's intolerant, for example, of bismuth, or it's not available. However, because the number of tablets, there's higher adverse events with potentially lower adherence. And the problem is also because there's still clarithromycin in there, there's going to be a lower efficacy because of the resistance to clarithromycin and also high metronidazole resistance in Kuwait. Now, the levofloxacin-based therapies have been recommended in the guidelines, mainly as second line. We shouldn't really use them as first line due to the poor eradication rates and resistance because of the widespread use in other indications, for example, respiratory infections. So just to finish off, just tell you what the bismuth quadruple therapy. So this is the one we have in Kuwait is the Pylori, which is the combined tablet. So it consists of bismuth, subcitrate, potassium. Each capsule is 140 milligrams, plus metronidazole 125 milligram, tetracycline 125 milligrams. And the dose is 3 capsules taken 4 times a day with meals. And it's very important that we combine the Pylori with proton pump inhibitor twice daily before meals. So remember, the Pylori is taken with meals, the PPI is taken before meals. And very important, just to tell your patient about the adverse events that can happen with this treatment, which they can get dark stool, dark urine, dark tongue, sometimes some abdominal pain, nausea, and dysgeusia or change in the taste, usually a metallic taste because of the metronidazole. Most of these are mild and transient, and if you advise the patient take the pills with meal and with plenty of fluids, it should decrease the adverse events. Thank you very much.